Welcome to Backstabbers, the only podcast where we're not just sticking needles in your back, we're talking behind it too. All right, we're back with another episode of Backstabbers, hosted by Lacey, Sarah, and Alex. How we doing, ladies? How we feeling?
Good.
Great. I'm over the snow, but I'm good.
Amen.
As they braving that Midwest snowstorm.
Yeah.
That hit.
No snow
I
days
hate
for these
that as an
mamas.
adult. It's just not fun. Like we just have to risk our lives to go into work.
Yeah, for elective
And then we don't know what to do
surgeries.
with our children.
Yeah.
For elective surgery.
I don't mind for
Not-
OB, you can't schedule that around weather. Patients in the hospital with like appendixes that are angry, or you've fallen and broken a hip. Like those are things we can't time around the snow. But elective cases on snow days drive me bonkers.
Carpal tunnels.
I don't think.
Yeah.
I think one canceled today. I think just one.
Oh, everybody crawled there. I mean, like everybody pretty much showed up today.
Yeah.
It was unbelievable. We had a hernia that literally told the surgeon that had to drive almost an hour that he would come pick him up if he didn't make it. And he said, I will come pick him up. I'm like, for your hernia?
I do understand from someone who's had surgery, it is a lot of scheduling. So you've probably scheduled around work, or if you don't work, to have people potentially with you for like the recovery. So I do understand that part of it. But I think risking people's lives is, a little
these
much.
70 and 80-year-olds who are showing up, and it's like, well, I know we're just, I don't know, fixing your finger today, but we don't want to do your hip with that.
Let's not add other things. Yeah.
Which we had happened last year when it snowed really bad.
Yeah.
I forgot what they came in for, but they ended up breaking an extremity of some sort on the way in.
Last year we had the surgeon walk down the interstate because he wrecked his car.
I did. Yesterday I did say I am not, if I get in a ditch, I will be walking home and not to work. So not happening on my watch.
Yeah, I only walk one way.
Yeah.
Back home.
And it ain't going to be to stay at the hospital either. I told him yesterday, I was like, I am not paying money to work. So I'm not getting a hotel room. I will walk here and walk back, but I'm not staying here more than I have to.
We did last year. We got a hotel room,
video?
a couple of us, and that was fun.
That was fun. That was a girls' night.
Yeah.
That's a good time. But Lacey, did you see that video of that nurse who got picked up by security and then got taken into the hospital, but nobody took the nurses home? So they were either trapped at the hospital, but this one guy, this video that's going viral right now, he's like, nope, I walked home, and he didn't have a coat.
He just walked home with his little fanny pack.
Of course, they picked you up but didn't drop you off.
Right.
They did that to me when I worked in the ER. They did that to me one time when it snowed, and they don't tell you anything. They're like, we'll just come and pick you up. It's no big deal. Like, and I was like, okay. And then they did not I was at the hospital for I can't remember if it was 2 or 3 days. And I was like, y'all didn't tell me to bring anything. I haven't showered. I don't have a toothbrush. So I was like, never again.
Yeah.
Hard yellow socks you can get.
Grippy yellow socks. They're real cute. You can have some mesh panties. Mesh panties.
All right. We did have some hay anesthesia questions. Let's jump into them.
Yes. First of
Hay
all,
anesthesia. Did you try the Sonic fries?
And my answer is no.
I have not.
Lacey, I know you went to Sonic. Did you try them?
I have had them. I was the only member who had them
Yes,
already.
she was.
Yeah, that's right.
Here's the thing. If I'm at Sonic, I'm getting cheese sticks, hands down, every time. It can be 5 days in a row. I don't care. Give me the mozzarella sticks.
All the time.
So I did not have them between last taping and this one, but I have had them. I prefer the original.
Okay.
I will say, so me and Alex and then one other girl we work with carpooled today to try to be safer. And we did, McDonald's was the only place that opened. So I did have McDonald's fries today.
Nice.
I was so happy. I had ice and fries in the same.
Yeah, that's a good
McDonald's
day.
Diet Coke. We had it.
I was like, I'm just so happy. It's unrealistic how happy I am.
I did ask my husband. He never listens to the podcast, but he caught part of it because I made the whole car listen to it. And anyway, he was like, well, I mean, obviously the wavy fries are better. Why is this even up for discussion? And I was like, because I like the original. So we got 1 for 1 in my house.
I mean, I'm not going to say no to a fry, but I do need to. I mean, for scientific purposes, I need to do it. I need to try them.
Yeah.
Yeah.
You left our
I'll
listeners
take one
hanging.
for the team.
Okay. All right. Next, hey, anesthesia question. RSI sounds like the way to go for everyone. Why would you not do that?
Yes. So the safest thing is for you to have no food in your stomach and that there is no risk. We put pressure right here on your neck in a pretty significant amount, but there's a lot of new studies saying that that does pretty much absolutely
Doesn't do
nothing. So
anything.
the
Yeah. Oh, I feel like the
risk
circulators,
that you
unless
could,
you're,
most people don't do it right anyways. I actually
yeah,
rarely see somebody do it right. Like unless the patient's like, oh, I don't, it's very uncomfortable with how much pressure. I can't remember how many pounds of pressure is.
I think it's like 20 newtons, which who knows what that is. And don't quote me on that.
I was going to
only
say
know 'cause
20 or
a
23.
student and I were just discussing this.
Yeah.
But I remember a fun fact as I was had to re-educate. We had a bunch of new circulators. This has been a couple of years ago, and I was asked to re-educate where we were on some of those things. And so I had researched, and one of the things they said to tell people is to put your fingers on like the bridge of your nose, and how hard you would push for that to hurt is how hard you should push for that. So just
which is a lot. I mean, it's
a
actually
lot. It's more than, because you'd feel like you're hurting someone, you know.
Oh,
So I feel like most of the time
you're gonna hate it, but you're not gonna be awake for long.
Yeah, because you don't always have another anesthesia provider available, and we only have two hands, so we can't do it all. So you are sometimes relying on, you know, an untrained set of hands helping you there.
And
the other thing I would say,
technically-
the reason we don't RSI everyone is the medicine that we give for that portion 99% of the time. We can use a different one in a kind of a different way, but 99% of the time we're using succinylcholine, and it can give you myalgias, meaning like you hurt all over. So it makes you kind of twitch. That's how we know that it's working. And it can cause you to have some like full body muscle soreness after the fact. Oh, Sarah, you went dark.
I did go dark.
Let's put her back in the light, people.
It's better for everyone.
It also, it is a very rare complication, but it gives us a higher chance for malignant hypothermia, where you can get like this very deadly high temperature. What am I missing?
It can affect your potassium level.
Potassium absolutely
can
can
increase your
cause some
potassium.
cardiac arrhythmias for sure.
Mm-hmm.
So it's not one we just want to jump to and give to everyone. And there's some people in the population that we can't give it to at all. Yeah, it says they're trying to reconnect. You know, it may be my fault because I'm at my parents' and I'm down here recording in the shop, and my service is probably not the best. I got snowed in at my parents'.
You are glitching a little.
Okay, so we can't jump to the succinylcholine, the medicine we give for RSI, to certain populations. So like your dialysis people, anyone with a chronically high potassium level, anyone with a family history of that MH or malignant hypothermia. So there's just some people that we definitely want to avoid it with. We try not to give it to kids.
Mm-hmm.
So it's not one we just want to willy-nilly, we're going to give it to everyone.
Mm-hmm. If we can wait because it's an elective procedure, then we can. That's the safest thing for you, and that's what we want to do.
Yep.
Because when we give you our sleepy medicine, it actually can relax you like a paralytic does, and like even if you have been waiting 8 hours and you have bad acid reflux or something, it can still come up and it can still go in your lungs, but it's safer than having a bunch of food that would go down in your lungs, and we'd just rather you not.
Yeah.
Just don't, please.
Just don't do it.
But that was a great question. You know,
it was a good question because they were like, it's so simple. Why don't we just all be RSI'd?
Yeah.
Like, no, thank you. And if we can do a less invasive airway, like an LMA placement that doesn't go all the way into your lungs, it's usually better for you. And especially if you have COPD or lung disease, it's better not to mess with your lungs like that.
So that was another hey anesthesia question, was kind of briefly describe some of the different terms and things that we say that we may not realize that we're saying that the general population may not know what we're talking about. So let's maybe briefly discuss like some of the different types of anesthetics, some of the equipment we might use. I think that was kind of what they were looking for in the question was what I gathered.
Perfect. So first we can start with a MAC. Let's talk about a MAC case.
I like it.
Sedation.
Alex, you go. Tell us what it is.
MAC, monitored anesthesia care.
Not a Big Mac.
That is well played. You worked it in.
You're welcome.
Worked it right in there.
Love that. That's a case where we sedate you enough to where you're not going to be awake or aware of things. So I tell my patients, you're going to be sleepy enough to not know what's going on, but awake enough to be breathing on your own. And then if you can't breathe on your own, we're in there with you the whole time and we'll assist you with that breathing. And sometimes it's as simple as a chin lift if you're obstructing, if it's for like a colonoscopy or an EGD, port placements, trying to think of other MACs that we commonly do, but it puts you in that twilight sleep. And most of the time we use the medication. Most of the time we use the medicine called propofol, the Michael Jackson drug, and it puts you in that twilight sleep. So you really just don't know what's going on. But with that type of anesthetic, you might hear us talking towards the end. It's not a general anesthetic, so you're not completely out of it. And so that's where sometimes confusion can happen because if you do hear talking or if you do kind of come to or remember certain things, it's not what am I looking for? We don't necessarily want that to happen. It can happen and it's okay. And it actually might be the end of the procedure and you're coming to where we're finishing things up and then we're taking you straight out to pack you. You're not awake in the middle of a general anesthetic where they're doing something crazy intensive. And
we do get people tell us that they woke up during surgery, and when I talk to them and they tell me it was a colonoscopy or a heart cath, and I'm like, that's why I very clearly state when I'm telling people about the procedure, I'm like, you will wake up back there. It's because I want you awake, and then I will completely wake you up in recovery, but you will wake up in that room because I want you to. Hey, Pumpkin.
hey.
Why is it always my family? I have the oldest children.
Well, that was your oldest child.
That is my oldest child. That is 100% accurate. Dear, I love you, but everything you do, we can hear. So if you could please go back up to the main house, that would be wonderful. Love you, Mina.
We love you.
Love you, Mina. Back to MAC cases out, but sometimes we do you could do a carpal tunnel or a trigger finger under a MAC, and the surgeon actually wants you to wake up to move and open and close your hand to see if it's still getting triggered, stuck.
Because you're the only one that can activate that. Like us moving your hand can't do that for you.
It's not the same. Yeah.
It's not the same.
So, and we can combo that with like some local or like a block of some sort. So sometimes you'll hear us say like we're going to do a MAC local or give you a block and then just keep you kind of sedated. So that it can definitely partner. I'm telling you, it can definitely partner with some different things. And the backup plan would always be a general anesthetic. So if it's more than you bargained for, we'll just slip you on off to sleep.
Yeah.
Or if you puke in Sarah's face, that buys you a tube.
Most carpal tunnels are actually done where we give you a big slug of medicine. They numb it up right here. They numb it up right here and make your hand numb. And then you wake back up during the procedure. And because it's only a 10-minute procedure. And so people do get confused about that too. So I always warn them, like, once you wake up, we want you awake.
That's on purpose.
So
that's,
but that's why we're there, is to always make sure you're comfortable. So if you ever are uncomfortable, we are there to fix that because we have all the drugs. Legally.
Exactly. And that's, so we're not stuck to just the propofol, although that might be our main one. There's other adjuncts that we give you too. So if you hear, the word Versed or Precedex or ketamine, those are all things that we use in combo, and some narcotics too, even if we need to. So that's MAC case.
It is.
All right, Sarah, since you love Ativa.
I do. Okay. So
you do? Was that sarcasm? You do?
No, I do. I love Tivas. I would do them on everyone.
Okay.
I do.
Okay.
They just wake up and they're like, like clear-headed, and they're not confused. They can move themselves over. I just love it. So it's totally through your IV instead of giving gases. Now, The gases are wonderful and easier to manage because we have numbers that we monitor that gas on. But with Ativa, we usually do a propofol infusion the whole time that we put you to sleep with initially. And there is a little sticker on your head that we can monitor your brain waves. And that actually tells us how deep asleep you are. So there are numbers that we like to keep it in between. So we actually can't tell how asleep you are. And we usually use the other drugs too, like Precedex and ketamine. But we use it for a lot of people with that get sick during surgery because the gas is usually what makes people sick. So,
Pretty fair.
but we're monitoring all the time. It makes people nervous because there's not that number that we're looking for, like on the gases that we can tell at exact amounts on there, or your IV can infiltrate. And so it takes a little bit more like meticulous to be watching your IV and all those things. But usually people wake up pretty clear headed. They don't have that foggy gas after you wake up, but it's just nice and simple. But
And with Ativa, you still place the airway.
Oh, yes, you can do
Absolutely.
any airway with it. LMA, endotracheal tube. It's just cleaner. It's more of an intense procedure than like if you were doing a colonoscopy, you would need to be all the way asleep and us managing your airway. And the biggest thing is they charge different for it. And that is one of the reasons we don't do TIVAs on everybody, because that's a thing. Like people are like, why don't we just do them on everybody? It would be very expensive, especially for long surgeries that are hours and hours. It would be a very expensive anesthetic.
Well, it's not, because our time, we get charged by like, and I think this is universal, anesthesia charges, I think in like 15-minute or whatever it is, time increments. What makes it more expensive is the drugs themselves. So propofol, Diprovan, that's the other name. It's much more expensive than Sevo, and you have to use a pretty good amount especially if it's a several hours long case. You'll
And
be using.
Sevo is an anesthetic gas.
Yes, sorry, that's our probably most popular gas. Would you guess?
Not for Sarah.
Nationwide. I know. I mean, so definitely
Just
places
kidding, but yes.
have Des. That would be the other one, and we love it. ISO's still out there. I feel like it's mostly for hearts these days. I mean, I don't even. We don't even have it.
We don't have it
at either of the places that I'm at. But,
hearts. Yeah.
so probably Sevo would be the most common. I'm gonna guess.
Mm-hmm. I think, and it's cheaper.
It's cheap.
Does.
Yeah.
And we use different gases for different things. So like sevoflurane can hang on longer, and desflurane can be breathed off quicker. But there are things about desflurane that are not good, and that Sevo's better for.
Mm-hmm.
Yeah. I love Des, and unless someone's like super reactive and being a pain in my butt, I'm usually giving Des because I'm with Sarah. I do like Des.
Yeah.
But
and Lacey, you take
just
over general cases since we're talking about the gases.
So general would be like the sister to Tiva, right? So same in that we are putting something in your airway, whether it's an LMA or an ET tube. But instead of a continuous infusion through your IV, we're giving you gases through that airway device, and that's what's keeping you asleep through the procedure. So all we're talking about is what's keeping you asleep through the procedure, and that can be through your IV and a Tiva, or it can be through the airway device, and that would be what we would consider like a general. That's what you'll hear most people say. So very, very similar. And then as far as devices, since I feel like we've kind of talked about two, and I'll post some up so people can see pictures of them, but there's two main airway devices for these generals or Tivas, and that can be an LMA or an ET tube. An ET tube is one that goes all the way actually into the trachea, has a little balloon to keep it there right below your cords. It's the safest as far as like not letting anything that was in your belly up into your lungs. It is definitely a secure airway. Doesn't come without risks. And if you're someone who's bad COPD or really reactive, we can make you just angry and hate that tube, and we're hating our lives. Alex, you want to talk about the LMA?
Sure. Yeah. An LMA, it doesn't go quite as deep as the ET tube. It's kind of in the back of your throat. It does look really funky. So when you put the picture up, you're like, oh, that can fit in my mouth. It can.
It does.
People actually do it awake.
It's true. There are funny videos. So you should Google that in your free time sometime. But we give those meds to make you really sleepy at the beginning, and then we place that in your mouth, back of your mouth, kind of your throat area. The issue with that is that it doesn't go all the way into your lungs. So if there is any type of aspiration or any contents from your belly that comes up, it can go back into your lungs because it's not fully blocking off that
It usually
area.
helps prevent it from going in there, but there's always a risk because we don't have that balloon inflated to protect your airway.
And
I will say
again, that's one.
we have newer LMAs now that have like a gastric port. So like the iGels and the what are the other ones? The Ambus, I think, have it. Is that right? Y'all help me remember.
Yes. Yeah.
I believe
Yes.
those are the
It
two
is those
that
ambu
have a
ones. Mhm.
separate little port that you can actually put a teeny tiny, doesn't suck much out, tube in, kind of like we talked about last week, the OG tube, to help drain anything. But it also just has a nice little seal to protect your airway from those juices. Now, it is not as good as a true ET tube, but it will help maybe keep some of it out.
And you can't
That's-
suction chunks out of it. So no food.
So no food.
That's-
That's good to say. That's the one that you would have to be no food or drink prior to your procedure, and then we
Yeah.
could safely place that.
So I do have a story from this week, Lacey. Alex, I can't remember if you were in there with me, but I had
can't
a
wait.
patient that balloon we inflate, it's important that you deflate the balloon before we take the ET tube out because it actually can damage your vocal cords. And so we're always very careful to make sure all the air is out of that balloon before we take it out. Well, occasionally you'll get a crazy patient and they'll grab it and rip it out. And there's not a whole lot you can do if they just randomly grab it. So anyways, I had this patient, history of drug use, and he smoked stuff and smoked cigarettes and all the things. But he was kind of acting a fool and he was coughing. And then he like, and then just shot out the whole ET tube, coughed it out with the balloon all inflated. And I was like, oh, well, thanks. But guess
You
who
get
it
a
was?
discount. I'm just kidding.
Guess who it was? It
Yes,
was our
this is the best part.
tagline patient.
Jesus
It was
wants you to
our
be
Jesus
quiet.
wants you to be quiet.
Quiet patient.
Yes.
It
That is
was
so
that.
funny.
I got to block him again, and he was like, I said, I bet you don't remember me. He goes, oh, yes, I do. And then
That's funny.
And then our CRNA that said Jesus wants you to be quiet snuck it at the end of the block and was like, Jesus still wants you to be quiet.
Yes.
Because
Yes.
he was talking all again about Jesus.
Oh, that's funny.
That's
Isn't it funny
amazing.
how
Good
you
for
talk
him.
about someone or you relive a story and it's like they show up?
Yes.
Yeah.
Because that's what happened with me in the overalls epidural. I
Right?
had
Oh,
mentioned it into
yeah.
the universe again, and then there they were.
Oh gosh. I was like, it's so good to see you. You just have, you don't even know what you've done for us.
Right?
But anyways, yeah, I should have given him a discount because he did my job for him. But I was like, okay, we can go to recovery now. We're good.
Thanks for that. Hope your throat's not
And
sore.
Yeah, I know. If it is, it's on you.
That's your fault.
But I do want to make it clear before we put the tubes down for the general anesthetics, we do what we call a lash reflex. So that is how we know you're not responding, you're not with it anymore. Even if you're like super asleep, if I rub your lashes, they'll flutter. And I'll know that I need to give you a little bit more time or a little bit more medicine. So there are ways we check. We don't just shove that down there, if we're not sure you're asleep. There are ways we know.
Mm-hmm.
Yep.
So, yeah.
So then another type of anesthetic would be like a spinal or a regional. So like if you're having a C-section, that's a common time. Some places for total joints do spinals. So there's definitely times that we can do that little shot into your back. We kind of talked about it a little bit briefly when we did the epidural, and Sarah mentioned that ligament and that very last little bit and how with an epidural, we don't want to get the CSF. Well, with the spinal, we do. So we go until we get that CSF coming back to us, inject a much smaller amount of medicine and give you something to help numb you. Can also give some narcotics through there to help for pain control that way too. And then that lasts
it's also a
usually
much smaller needle.
2-ish
so
hours. Yeah. Much smaller needle. That's a good point.
Less risk for a headache, I should say.
Still long. It's still long. So don't be confused by that. When we say smaller, we mean diameter.
Diameter. Yeah. I could show both of those needles on there too, just for comparison, like side by side.
They look scarier than they are.
It's true. Honest to God, they are So they're the same size as IVs. So
True.
as far as diameter. So
And we numb it up first, so
Yeah.
that's why it makes it more tolerable. So it's actually easier than an IV for y'all.
So
Yeah.
it's just not as scary as people make it out to be. It's really
Yes.
not. It's just long. That's all.
And we can all say because we've all had it done.
It's
All
true.
had it.
That is true.
Yep.
I've even had a spinal. Have either of you had a spinal?
No,
I have
actually, no.
not.
What did you have a spinal for?
I had
Knee?
my ACL done when I
Knee.
was
Her knee, yeah.
16, somewhere in there, and had a spinal. Sure did.
I honestly, I want to experience it. So when I'm describing it to my C-section girls, that I mean, I explain it as if I know because I've seen all the ones and how they
Right.
react to it. However, I wouldn't mind knowing from experience because
Yeah.
that made a
I will
difference with
say
other girls.
I did get some sedation too then through the ACL. So like I remember my legs getting heavy, but they also did it in the OR. So and I feel most people do. You do still see occasionally they're done in pre-op, but it was done in the OR. I was already probably versetted it up because I don't remember a whole lot about it. I remember kind of the warm and tingles, and then I just slept. When I woke up, I can remember I could move my toes, but that was it. But you're 16 and nothing scares you at that point. So you're not really thinking, oh my gosh, I'm paralyzed. Because I feel like that's probably what most people, even if we really educate preoperatively, it feels wrong to not be able to move.
But yeah, and then we do blocks as well. Like if we, but a lot of the times when we do blocks, we still put you to sleep. But we can do blocks and then just lightly put you to sleep because they work so well.
So at this other place that I'm working, we do a ton of blocks and then just some kind of like a MAC sedation style snooze you just a little bit. Although for one of ours is a hand guy, and so he does like for them to be awake if they're tolerating it, to move for those trigger fingers or for the carpal tunnel or for whatever. He'll sometimes ask them to do things.
And when we go in for a nerve block, we're injecting a local anesthetic. Nowadays, we have an ultrasound that we can use so we can see where your vasculature is and also where that nerve is. And so we can see exactly where we're injecting that local, and we can do it relatively safe, much safer than how it used to be done.
Than old school, yeah.
Yes.
Old school was just looking at your anatomy and guessing. And usually they put enough volume that they 50-50 got it right. And then they had the nerve stem, which I guess some people still use. I haven't used one in forever.
We have a guy that still likes to use it.
Yeah. They do at this other place too. And I was like, haven't used one in 10 years, not starting now. I'm not going back. I refuse. I've got the ultrasound. It's superior in all ways. Because here's the thing. With the nerve stem, I've seen it where, especially like those diabetics, you can be right next to the nerve and they're not doing anything. Or you can have someone who is hyper reactive and you're like barely through the skin and they're already twitching. Well, either time, you're just going to trust the ultrasound. Yeah. So why are you even putting that in the scenario if you're just going to trust the ultrasound anyway?
And with the ultrasound, I mean, you can see the entirety of that needle and where the tip is,
right,
and where that nerve is, so you can see where it's hitting.
And I will say we don't do those blocks when you're asleep because we do like to give sedation, especially where we work.
Some places do. Most places want you to be awake.
We want you to be awake enough to where you can, because if we get into your nerve, we call it intraneural, and we inject, you can actually injure the nerve, but it sends a shooting pain. Like if we're doing your shoulder down your arm, and you can say, oh, that's a shooting pain. And then we know we need to back up and reposition. Now, I will say I had an interscalene block, which is up here for my arm, and they did not give me sedation. And that's just brutal. Because it's not super comfortable. I mean,
even if you numb the skin, it's not a comfortable feeling.
And so I feel pressure, and
I do like to sedate people for it, but I still like them to be able to communicate. Most people don't remember afterwards, which is perfectly fine with me. Communicate.
I always joke
but don't remember.
The sedation is like a good spicy margarita or an evening in Vegas. Like you're gonna be awake and you're gonna remember it right this second, but it's gonna get real fuzzy later. And you probably won't remember it afterwards, but you're awake enough to woohoo and tell me you're having a good time or not.
I love doing blocks with you, Lacey. I love all of the little verbiage that you use in explaining.
Well, and now because I'm at this other place sometimes, I've got like a whole new audience. So I'm getting to like say it for the
Reuse
first
it.
time with these people.
That's awesome.
You're like, I'll be here tomorrow. Thank you. Thank you.
That's
We
like
are
when
your
they-
favorite cocktail waitresses, though.
Amen. I do
That's true.
sometimes with like, especially the like 16 to say 26, I sometimes will whisper at the end, I'm like, don't do drugs.
Yeah. I'm like, we're legal. This is legal with us.
I know I
Little
made this really
subliminal
fun,
messages.
but please don't go do drugs now.
What's the guy? I should know this, and I know I'm going to be embarrassed by saying this, but what's the Friends actor who passed away?
Matthew Perry.
Yes.
I knew immediately this is where you were going, actually.
But patients will say that because I'll be like, "Yeah, I'm using ketamine," and they're like, "Didn't he die from that?" And I'm like, "Yeah, and I'm actually using the Michael Jackson one too." So,
Well,
that's
he didn't have us.
That's right.
Exactly.
Forever, I wouldn't say propofol. I would say Diprovan because people got nervous because of Michael Jackson. I feel like now there's been enough time that one's kind of worn off. But ketamine, I do get that one sometimes. Although I think because it is in the news for other things and
the horse
people
tranquilizer.
know what a
That's
high,
what they say.
what a good high you can get from it. I don't think they're as scared of it. I don't know. Maybe I'm wrong. Let us know.
I do need y'all to pause and read the text message that you just got. So we're going to have to make a little shout out here to one of our sexy male ortho reps. Because he found our podcast, which is going to be probably not in our favor.
We
No,
may
it is
regret that. Yeah.
He said he wants a full episode about hot male reps.
Well, when we get one, we'll do that.
We'll have to have him on sometimes. He's got some great stories about drive-thrus that will offend everyone.
Okay.
Yeah, I don't know. We might get canceled if we have him on.
I know.
If we have him, exactly. Well,
He would definitely get canceled. So there's your shout out for now. No, like he
Okay.
did. Yeah.
Let's do word of the week. What's our word of the week going to be? Game time. We've done kind of an educational episode, if that helps at all.
I was thinking airway. We could do loogie.
Oh.
How about canoodle?
Canoodle. I was going to say we could make it snow day.
Oh, we could. That'd be kind of easy to work in right now, though.
Because
That's true.
Did your kids have day off because of the snow day?
Yeah.
Canoodle. I like canoodle.
Canoodle, yeah.
French fries, since neither of you heifers ate French fries from the proper
From
place.
Sonic. Yeah, I was gonna say, let's get McDonald's.
Everybody's gonna be like, "Are y'all hungry all the time?" There's
All
like
the time.
Big Mac.
The answer
and
is
French
yes.
fries
The answer is
literally all
yes.
the time.
always food.
Literally all the time. Like when I was packing my car in case I died on the way to work today or ran off the road, I had so many snacks and drinks and like I could live in my car for a solid month.
It was great.
Sarah,
when we
you
left
always
the
have
hospital
snacks.
too. Well, when
You
we
are
left,
afraid of being
put
without
more-
food.
It's unbelievable, actually. Like I live in a third world country or something.
Yeah.
Me and one of the other CRNAs have the same purse, and she picked mine up on accident. She was like, "Why is it so heavy?" I'm like,
her snacks.
There's so many snacks in there, and
All the
probably
snacks.
3 drinks. I usually
For
have
my-
at least 3.
for my kids.
Yeah, it's for my
No, for
I buy
her.
gold.
Mm-mm.
It's all for me. They make me
Okay,
happy.
word
I
of the
get
week.
sad when I don't have snacks.
Canoodle. Are we gonna do that one?
We can do canoodle.
I like canoodle.
All right, canoodle it is, people.
Canoodle it up,
Work
folks.
it in.
And then I don't even want to remind you, but let's do our nail check.
Oh God, mine are terrible. I was supposed to get them done today. They are still the podcast ones, still hanging on, but I've
They
cut them
are.
because they were too long.
Oh,
Look, that one's broken. I feel like Alex.
Oh gosh, I'm also. I mean, mine
I'm
are, look
missing-
like they always do.
I'm
Oh.
missing one on my pinky, and then this hand. Is
Mine are
mine.
all right. Backstabbers out.
Backstabbers out.
Jesus.
Bye.
Bye.
All right. Jesus wants y'all to be quiet. Bye, y'all.
Be quiet. Backstabbers out.
Bye.